Treatments in respiratory disease. Domiciliary oxygen therapy. Blood returning to the heart from the tissues has a low PO2 and travels to the lungs via the pulmonary arteries. The pulmonary arteries form pulmonary capillaries, which surround alveoli. Oxygen diffuses from the high pressure in the alveoli to the lower pressure of the blood in the pulmonary capillaries. After oxygenation, blood moves into the pulmonary veins and is returned to the left side of the heart to be pumped to the systemic tissues. In a perfect lung, the PO2 of pulmonary venous blood would be equal to the PO2 in the alveolus. Three factors may cause the PO2 in the pulmonary veins to be less than the alveolar PO2. Ventilation, perfusion mismatch. In a perfect lung, all alveoli would receive an equal share of alveolar ventilation, and the pulmonary capillaries that surround different alveoli would receive an equal share of cardiac output. Ventilation and perfusion would be perfectly matched. Diseased lungs may have a marked mismatch between ventilation and perfusion. Some alveoli are relatively overventilated while others are relatively overperfused. The most extreme form of this is a shunt. Shunt occurs when deoxygenated venous blood from the body passes unventilated alveoli to enter the pulmonary veins and the systemic arterial system with an unchanged PO2. Slow diffusion. In the normal lung, the diffusion of oxygen into the blood is very rapid and is complete, even if the cardiac output is increased, exercise, and the blood spends less time in contact with the alveolus. This may not happen when the alveolar capillary network is abnormal, if there is lung fibrosis and emphysema. Domiciliary oxygen therapy is the domiciliary administration of oxygen to patients with lung disorders with the aim of correcting hypoxia while maintaining PaCO2 and subsequently pH within an acceptable range. The advantages of domiciliary oxygen therapy include the following. Increased survival. 2 studies have established a place for prolonged oxygen treatment in the management of chronic obstructive pulmonary disease, COPD. The British Medical Research Council trial, which evaluated oxygen for 15 hours daily versus no oxygen, and the National Institutes of Health Nocturnal Oxygen Therapy trial, NIH NOT trial, which compared 12 versus 24 hours of oxygen daily. Both studies showed a survival benefit in selected patients with cor pulmonale. In addition, the NIH NOT trial showed better survival in patients with continuous oxygen therapy compared with nocturnal oxygen therapy only. Reduction in hematocrit. This leads to improved pulmonary and systemic blood flow. Neuropsychological improvement. Indications for long-term oxygen therapy. Chronic hypoxemia due to COPD, chronic asthma, diffuse parenchymal lung disease, bronchiectasis, pulmonary vascular disease, cystic fibrosis, idiopathic pulmonary arterial hypertension, pulmonary malignancy, and heart failure. Nocturnal hypoventilation due to obesity, neuromuscular disease, chest wall disorders and obstructive sleep apnea. Palliative use. Patient selection. The need for oxygen therapy should be assessed in all patients with cyanosis, patients with polycythemia, Patients with cor pulmonale, edema. In COPD, patients with a forced expiratory volume in 1 second 30% of predicted. All patients should be on optimum treatment prior to assessment for long-term oxygen therapy, LTOT. LTOT is indicated in patients with daytime PAO2 90% for more than 30% of the time. Once a patient fulfills the criteria for LTOT, the appropriate flow rate that can achieve a PAO2 greater than 7.3 kPa should be determined by checking the arterial blood gases on oxygen. In the NIH NOT trial, the majority of patients needed 1 to 2 L/min of oxygen delivered by nasal cannulae. Patients will need an additional 1 L of oxygen during exercise and while sleeping. Ambulatory oxygen. All patients with chronic lung disorders should be assessed for ambulatory oxygen requirements. The 6-minute walk test is a simple and widely used stress test that makes it possible to evaluate the functional status of patients with lung disorders and their ability to carry out activities of daily living. The test measures the distance walked on a flat surface in 6 minutes and requires a constant level of effort similar to that needed by the patient to carry out activities of daily living. The test has also been used to assess exercise-induced desaturation. The American Thoracic Society guidelines for domiciliary oxygen state that ambulatory O2 should be prescribed to patients normochemic at rest with evidence of exertional desaturation to 88% or less. Short-term ambulatory oxygen is associated with significant improvements in health-related quality of life. Ambulatory oxygen can be prescribed in 3 groups of patients. Patients on LTOT who are mobile and need to leave the home on a regular basis. Patients on LTOT who are housebound and unable to leave the home unaided, but may use ambulatory oxygen for short, intermittent periods only. Patients without chronic hypoxemia but who show evidence of arterial oxygen desaturation on exercise. Short burst oxygen therapy. Short burst oxygen therapy, SBOT, is commonly prescribed for patients who do not fit the criteria for LTOT but remain breathless after minimal exertion. It is usually provided from cylinders. SBOT either before or after exercise probably does not benefit the majority of patients with moderately severe COPD who exercise for more than a very short period of time. Modes of administration of oxygen. Oxygen cylinders. Oxygen concentrator. Portable small lightweight cylinders for ambulatory oxygen delivering liquid oxygen. Continuous positive airways pressure. Continuous positive airways pressure, CPAP, is a system that delivers a constant pressure to the airway, via a tube and a mask, thus acting as a pneumatic splint preventing upper airway collapse. Colin Sullivan introduced it in the early 1980s for the treatment of obstructive sleep apnea, OSA. Prior to this, the treatment of choice for OSA was tracheostomy. The pressure delivered can be titrated to achieve adequate upper airway patency. The interface delivering the pressure can be nasal, full face or nasal pillows. The advantage of the nasal pillow is that no headgear is required to keep it in place. If needed, oxygen can be delivered via the CPAP. Indications. OSA. The treatment of choice for this is nasal CPAP. This prevents the nocturnal collapse of the upper airway, causing apnoea and hypopnoea, thus preventing sleep fragmentation and daytime somnolence. The pressure needed to achieve this can be titrated by repeating sleep studies on CPAP. However, auto-titrating machines are now available, thus avoiding repeated sleep studies. Neuromuscular diseases. Inspiratory upper airway collapse can complicate neuromuscular diseases affecting the chest wall, but CPAP can prevent these episodes. CPAP also prevents atelectasis in neuromuscular and chest wall diseases. Thus, in such patients with type I respiratory failure, nasal CPAP should be considered. Paralysed hemidiaphragm. CPAP can prevent the flail action of a paralysed hemidiaphragm and thus improve the efficiency of inspiration. CPAP may be indicated in any pulmonary disorder that results in severe oxygenation abnormalities. FiO2 greater than 0.6 is needed to maintain PaO2 greater than 8 kPa, in the presence of a normal PaCO2. Pulmonary edema. CPAP in patients with severe cardiogenic pulmonary edema can result in early physiological improvement and reduce the need for intubation and mechanical ventilation. Central sleep apnea, CSA. Up to 50% of patients with severe heart failure, ejection fraction 45%, suffer from nocturnal CSA, presenting with daytime somnolence and paroxysmal nocturnal dyspnoea. These patients have increased morbidity in comparison with patients who have congestive cardiac failure without CSA. CPAP can help relieve their daytime symptoms. Complications. Dry nose, nosebleeds and sore throat. Nasal congestion, runny nose, and sneezing. Irritation of the eyes and the skin on the face. Abdominal bloating. Headaches. Leaks around the mask because it does not fit properly. Non-invasive ventilation. Respiratory failure results from an imbalance between the capacity of the ventilatory apparatus, including respiratory center, spinal cord, intercostal nerves, chest wall, bronchi and lungs, and the load placed upon it. This imbalance can be acute or chronic. In acute respiratory failure leading to respiratory acidosis, some form of transient ventilatory support is needed, while medical therapy corrects the insult. Non-invasive ventilation, NIV, is the delivery of ventilatory support without the need for an invasive artificial airway. It has a role in the management of acute or chronic respiratory failure in many patients, and may have a role for some patients with heart failure. NIV can often eliminate the need for intubation or tracheostomy, and preserve normal swallowing and speech and cough mechanisms. There are two types of NIV. Non-invasive positive pressure ventilation. Non-invasive positive pressure ventilation, NIPV, is usually delivered nasally or via a face mask, therefore eliminating the need for intubation or tracheostomy. It can be administered in a volume-controlled or pressure-controlled manner. A bi-level positive airway pressure device is used, which delivers different pressures during inspiration, inspiratory positive airway pressure, IPAP, and expiration, expiratory positive airway pressure, EPAP. Volume ventilators are often not tolerated because they generate high inspiratory pressures that result in discomfort and mouth leaks. Although positive pressure support is usually well tolerated by patients, mouth leaks or other difficulties are sometimes encountered. Supplementary oxygen can be given via the mask. Negative pressure ventilation. Negative pressure ventilation involves devices such as the iron lung, tortoise shell, or cuirass. The concept of mechanical ventilation first evolved with negative pressure ventilation. In the late 1920s, Philip Drinker introduced negative pressure ventilation and popularized the iron lung. He maintained an 8-year-old girl with acute poliomyelitis on artificial respiration continuously for 122 hours. The polio epidemics of the 1930s, 1940s, and 1950s led to the development of pulmonary medicine as a specialty and the iron lung as a workhorse. Ventilators delivering negative pressure ventilation fell out of favor as the use of NIPV increased during the 1960s. This was primarily due to an improvement in anesthetic procedures. Negative pressure ventilators support ventilation by lowering the pressure surrounding the chest wall during inspiration and reversing the pressure to atmospheric level during expiration. These devices augment tidal volume by generating negative extrathoracic pressure. Several of these devices, such as body ventilators and iron lungs, are available and either cover the whole body below the neck or apply negative pressure to the thorax and abdomen. Although studies of body ventilators have shown benefit in patients with chronic obstructive pulmonary disease, COPD, neuromuscular disease, and chest wall deformities who develop acute respiratory failure, prospective and controlled studies are lacking. Several uncontrolled studies have reported benefits of intermittent negative pressure ventilation in patients with chronic respiratory failure resulting from chest wall, neuromuscular or central hypoventilation. However, no benefit has been demonstrated in patients with stable but severe COPD. Because of their awkward size and their tendency to cause upper airway obstructions in some patients, negative pressure ventilators are not readily acceptable and NIPV is the modality of choice for NIV. Mechanism of action. NIPV decreases the work of breathing and the IPAP improves alveolar ventilation while simultaneously resting the respiratory musculature. This helps in blowing off carbon dioxide. The IPAP prevents any atelectasis and hence recruits alveoli in gas exchange. Externally applied EPAP decreases the work of breathing by partially overcoming the autopositive and expiratory pressure, which is frequently present in these patients. The patient generates a less negative inspiratory force to initiate a breathing cycle. Indications: acute respiratory failure leading to respiratory acidosis. This may be due to exacerbation of COPD, cystic fibrosis, or bronchiectasis, or pulmonary edema or pneumonia. Patients with one of the above conditions may develop acute respiratory failure and respiratory acidosis, pH 7.35 with raised PaCO2. Chronic respiratory failure, patients with neuromuscular and chest wall diseases, obesity hypoventilation syndrome, obstructive sleep apnea with hypoventilation, COPD with hypoventilation and, in fact, any respiratory disorder with hypoventilation may not be able to breathe out carbon dioxide, causing respiratory acidosis. Initially this occurs during the night and can be detected by overnight monitoring of transcutaneous carbon dioxide. Measurement of arterial blood gases at 7 a.m. is also helpful as it reflects nocturnal gas exchange. Such patients may also complain of morning headaches due to raised PaCO2. Nocturnal NAP can improve their gas exchange and symptoms. With disease progression, their need for NAP will increase. Contraindications: respiratory arrest, inability to use a mask because of trauma or surgery, excessive secretions, hemodynamic instability or life-threatening arrhythmia, high risk of aspiration, impaired mental status, an uncooperative or agitated patient, life-threatening refractory hypoxemia. Complications: ulceration of the nasal bridge due to a tight mask. This can be avoided by choosing the correct size mask and applying gel foam at pressure points. Gastric distension, hypotension, barotrauma. Practical details: if NAP is indicated, it should be started as soon as possible. Delays due to non-availability of a bed are unacceptable, as respiratory acidosis worsens with time. Before starting NAP in a patient with acute respiratory failure, decide whether the patient will be a candidate for intubation and mechanical ventilation should NAP fail. If so, the intensive care unit, ICU, team should be informed as early as possible. The initial IPAP and EPAP should be set up as per the hospital guidelines. Once NAP is started, measurement of arterial blood gases should be repeated in approximately 1 hour, earlier if there is clinical deterioration. If there is an improvement, treatment should continue on the same inspiratory and expiratory pressures. If PaCO2 is increasing, IPAP can be increased to help blow it off. If arterial blood gases are improving, they should be checked at increasing intervals. Once the acidosis is corrected, NAP can be stopped. However, if this occurs in late evening, it will be prudent to continue NAP overnight and stop it next morning. Always remember to optimize medical treatment for the underlying condition. Though NAP may be effective in respiratory acidosis due to exacerbation of asthma, such patients should be managed in an ICU with access to immediate intubation.